Good evening, everybody. Now we will start the one of the most fantastic sessions in our meeting, CardioGo 2021 Just Cases. And I have the honor to inform you that this session will be joined with the JACC case reports. And I think we have a bunch of fantastic cases which will be presented in this session. We have with us Professor Mohammed Sofihi, Professor of Cardiology, Alexander University, and the Chairman and the President of CVRAB. Professor Nabil Farag, Professor of Cardiology and the Head of the Ain Shams University Department, Cardiology Department. And I think we have also here a bunch of panelists, Professor Hibatullah Atiyah Ain Shams, Professor Ahmed Al-Sayed Ain Shams, Professor Mohammed Abdel Ghani, the Head of Cardiology Department, Cairo University, Professor Karim. And also this session will be moderated by Professor Mohammed Sada, Professor of Cardiology, Alexander University. I'd like to have the privilege to introduce my dear friend, the editor-chief of the JACC case reports, Professor Julia Grapsa. Hi, Julia.
Hello, everybody.
Do you hear us well? Everything is okay? Okay.
Yes.
Please let me leave the mic now for the sake of time to Professor Mohammed Sada to moderate this session and to introduce your elegant presenters. Professor Mohammed.
Thank you so much, Dr. Said, for this elegant meeting as usual. And I think this is one of the most attractive meetings we have attended since long time. Integrated cases, interactive cases, different case scenarios. And we are eager to hear from Julia about imaging in structural intervention in mitral valve. So we are waiting for you, Julia.
Thank you so much. It's a great honor to be a part of this meeting. And also a big thank you to Professor Sokbi, to my friend El Said, and to Professor Ashraf Reda. So, and I will speak about imaging in structural interventions and mitral, and we will discuss a couple of cases in between. So there has been, the interesting part is that there has been a huge explosion of the transcatheter mitral valve interventions and the devices that they are in the market at the moment. And for us as clinicians, it gives us the opportunity to help a patient that in like 15, 20 years ago would be considered high risk for surgery or even inoperable. So the echocardiography is important for planning these procedures and starting, for example, from the guidance for the mitral clip, we have always pre-procedural, intra-procedural, and post-procedural. So for us, it's important, and this is something that I say always to our fellows, that to look for your surroundings, to know, the etiology of the mitral pathology, to assess the scallops and the commissures, and to classify the mitral pathology according to the Carpentier classification, and then to identify any clefts or indentations, even if there is a degree of mitral annular disjunction, that is quite common. You may treat, for example, the mitral, and then the patient still to have palpitations if there is any evidence of mitral annular disjunction. But also the left ventricle, the left atrium, the right ventricle as well. So it's important not to only to isolate the mitral valve, but to assess everything around the mitral valve. And this is important to remember because echo is actually your first tool. And I understand that in many hospitals, for example, in Egypt and around the world, we have as the primary and only modality the echocardiography. And this is because, for example, when we have the functional MR, you will see a different balance between the forces, even between the papillary muscle displacement, the mitral leaflets, the mitral annular dilatation, the coaptation reduction of the mitral valve, then the relationship between the mitral regurgitation and the ventricular dysfunction, and this imbalance between the closing forces that create practically the mitral regurgitation. So it's important to assess and to know all our surroundings. Sometimes it may have value, the stress echo, in the sense that it will assess the left ventricular contractile reserve. And as you have seen from studies from Cleveland, the exercise treadmill test is adding prognostic value in transcatheter procedures for the mitral. But also we see from the guidelines, you all know the difference between the COAP trial and the mitral FR trial, that the mitral FR, they enroll patients with greater degrees of LV enlargement and less severe mitral regurgitation. So there was a patient selection issue, and that's why the results were very different. So it's important also to understand that we need to get the patients as early as possible before the end systolic diameter is so dilated that practically will not offer any benefit to this mitral regurgitation. This is an example of a 360 view of the mitral valve pre-procedurally, and we use new softwares in order to map the degree of mitral regurgitation. And you can see how, for example, this patient had a small cleft, as we call it, and the patient was accepted for a clip, but she had more than one clips here. And then this is another example of the same actually the patient that we discussed before, and you see how we assessed with color Doppler and all the modalities the valve. But also we in JACC case reports we published a nice editorial on how to use transesophageal echo intraprocedurally in order to assess. And here's a series of views. Practically, you start with mid-esophageal in TE. So it's a simple guidance on how to have guidelines on to assess the mitral valve. And this is an example actually on when we are overreacting, if I may say so. So here, this is a post-mitral clip assessment of position and residual gradients. This patient had a residual gradient of 7 because practically they used 3 clips and 2 vascular plugs because there was a tear of posterior leaflet during the mitral clip. So, when you have such a complication, then you need to stop, think how you can save the patient. If the patient, for example, would go to surgery, maybe the tricuspid the mitral stenosis would not be so tight. But here we ended up with 5 devices on a mitral valve. So sometimes it's important to stop and reconsider. And always, echo is important in post-procedural assessment. And you can see here how the regurgitant volume changes and also how the MR can be classified from mild up to severe, depending on the vena contracta, all the measurements that we know, the regurgitant fraction area, the volume, and the effective orifice area. So use all your senses and your eyes and, of course, your surroundings. Now, I have an example of a clinical case. She's a 70-year-old female patient, and in 2008, she had a mitral valve replacement with a 27 millimeter perimount prosthesis. And then, as you see, because she had a massive anterior MI, she has a very poor ejection fraction. You can see from the echo and from the transthoracic that her ejection fraction is quantified as approximately 20%. And because she was triggered by persistent AF, the last 12 months, she has been very out of breath in New York Heart Association class 3. Also, she's not a good candidate for surgery because she had breast carcinoma, she had previous infection of her ICD, her ejection fraction is very poor, so the surgeons did not really want to touch her. And despite being on optimal medical therapy, she was still breathless. And you can see the problem here is one of the discs is almost stuck and is not moving. Only the one disc from the bioprosthesis is moving. Therefore, this patient had severe bioprosthetic stenosis. So we need to do something because she's also very young. And here we use the glass, as we call it, of the TE, and we move the light where we want in order to assess the degree of mitral regurgitation and the degree of stenosis. And you can see that the valve is narrowed. So that's why it was quantified as severe bioprosthesis. Now, when it comes to the mitral prosthesis and transcatheter mitral valve replacement, Number one priority is the transeptal puncture. And here, we need it to be more than 4 centimeters in order, of course, not to avoid any complications. And here we see how we use the combination of CT, and then we adapt the CT to our fluoroscopy and to our TE measurements in order to make sure that the transeptal puncture will be enough for the interventionist to cross and to reach the mitral. And during the procedure then, what we're doing is we ensure that the guide wire and device delivery system are centrally located. And then we have the positioning of the device that's stable and whether there is any residual mitral regurgitation. Also here, it's important to exclude any cusp malfunction and whether we have any paravalvular leak, but also we check always the LVOT in order to make sure that we don't have obstruction. And that's here how they balloon the valve initially, and you can see here the air, how it looks. And then they placed the new valve and they expanded the valve, and this is the final result that is quite clear and open. But here, if you can see, the guide wire is still in, so the moment that the interventionist removed the guide wire, there was no residual leak, everything was normal. And here we have to assess the transmitral pressure gradient, the LVOT obstruction again, so to make sure that there is no residual MR, directly or indirectly. So as a summary, it's important to understand your surroundings, to provide anatomical measurements and to use 3D zoom when appropriate, and also to make sure that there is no LVOT obstruction. So I will actually move to the next one because just a few words about the CT, and these are my final slides, that with the CT is very important, and in many clinical cases, as the one that I showed you, it's important in order to predict the neo-LVOT, as we call it, and to make sure that there is no LVOT obstruction. So we measure the mitral valve annular dimensions, then the LVOT area, and the anatomical correlation. So it's important to have a great person who will know good CT. And also, it's important to adapt the 3D mitral annular segmentation on CT. It helps us actually being complementary with the echo, and again, to help us with the measurements, and especially when we have a small ventricle, meaning a small cavity, hypertrophied ventricle, and also significant mitral annular calcification. So again, we measure the annular calcification, we predict the LVOT obstruction with a neo-LVOT, we calculate the aortomitral angulation, and also we take into consideration the interventricular septum. In many cases, for example, they had localized septal hypertrophy, we need to make sure that that will not cause any problems. So that's my last slide, and with that, I would like just to say what are the take-home messages and what the future holds. For structural interventions and imaging, I think that if it was to go back, I would choose structural interventions as my subspecialty. Of course, now I've landed as the imager for structural interventions because we see a rapid development of the device and the technology. And it's also important to have to improve the durability of the valves and also procedural success. We will see more and more patients that they need structural interventions and new devices that they will provide lower mortality. So with that, thank you so much for your attention.
Thanks so much, Julia. Actually, this is amazing. Transeptal mitral valve implantation. This is a new hope for many patients, and I think this needs a very big trial to show the data. And I think Dr. Sobhi here has a comment. Dr. Sobhi.
Hello, Julia. This is a wonderful masterpiece lecture regarding the mitral intervention. My question to you for the mitral and even also the tricuspid, know that you are structures in imaging person. You know, in TAVI, we are concentrating now on CT and then pre-procedure planning. The echo is just for during the procedures. For the mitral and tricuspid means 3D and CT both for imaging. But in TAVI, it's just a valve and you put the device. whether balloon expandable or self-expanding. But in here, the mitral, we have a lot of devices and a lot of mechanisms. I mean, you have not only the valve, you have the cusp, the chordae, the papillary muscles. It's called mitral valve apparatus. So the mechanism, it differs. So how can you handle the mechanism you found in different patients with different devices, because you are claiming that the mitral clip itself is the only or the best treatment. But I don't think this, because you know, if you have a papillary, it differs from the chordae. If you have a TER, differs from the cuspal wide widening. How can you imagine this? If this is premature to decide?
That's a great point. And actually what we are doing is we provide a very thorough transthoracic and then a TE, and we take the measurements that will correspond actually to the criteria for the inclusion. You know, if the patient is eligible to mitral clip, sometimes we are able to predict whether the patient will need more than one clips. And, you know, for example, we had a patient 2 days ago that they said, oh, in order to fix that, we will need more than 3 clips and the patient may end up in critical care. So we decided not to proceed because there was high risk. We see also the dilatation of the left atrium. We see, you know, as you said, all the remodeling of the left ventricle. So it's important to take this. So for the mitral, if we have for the mitral clip, we are doing TE. For the transcatheter in valves, we are doing also CT scan in order to avoid LVOT obstruction. So wherever there is a risk of LVOT obstruction, we will do the CT scan. Even for the TAVI, we are doing CT scan. But if there is a non-reliable measurements, we will do also TE on the table to confirm. So these modalities are going together. When the one cannot cover all the secrets, for example, that the other one can provide, then we use both of them.
Yeah. Yes, Julia, I have a question for you. Do you hear me?
Yes, of course.
Yes, this is Nabil Farag. I'm asking about the transseptal puncture in mitral valve replacement, because we do a lot of mitral balloon valvuloplasty in our country. We have a lot of rheumatic heart disease, and we do mitral balloon valvuloplasty using different techniques like ENOI, single balloon, and double balloon technique using multi-track. And the site of puncture as regard transseptal is different based on the balloon I'm going to use. For example, if I'm going to use ENOI, I'm using a high puncture in the septum, and if I'm going to use multi-track or double balloon technique, I have to go lower in the septum, and this is for the success of the procedure. And we have a paper published before using transesophageal echo in guidance of this transseptal puncture and balloon valvuloplasty. And you said that you use a CT to guide the transseptal puncture. Why you don't use the transesophageal echo, which is very accurate in visualizing the septum, and we can be sure of the site of puncture in the septum, especially if we need to do a higher puncture for a mitral valve replacement?
So the CT was used when we have for example, transcatheter mitral valve in valve. When we have, for example, balloon or a balloon valvuloplasty, we don't use CT scan. We use only TE. And also for the transcatheter valve in valve, we use CT in order to see all the rest and to calculate also the transseptal puncture, to see, you know, the neo-LVOT, the calcification and everything. And then we confirm with TE. It's a TE-guided procedure.
Yeah.
So that's a good point.
Julia, Gamila Nasr, and I'm amazed by your presentation. It's very nice. I'm just asking you that you nicely outlined the role of echocardiography as an important message tool to diagnose or to help in managing the structural heart disease. I'm asking, is there a role for intracardiac echocardiography as an alternative to transesophageal echo in structural heart disease?
That's a great question, and thank you very much. So, I learned to know echo as my first modality. So I have seen intracardiac echo. Actually, when we were working with Antonio, one of our colleagues, he was a great friend of intracardiac echo. I've seen that in the cases that we are publishing, even on the 18th of August, there is a case that they used intracardiac echo for that specific reason, for transcatheter interventions, but we don't use it a lot in UK, I think for a cost, it's a cost perspective. So I haven't been trained. I know that there is, of course, efficiency, but I cannot comment from my own experience.
So, Julia, another question, please. As regarding the size of the valve introducer sheath, we of course this is a venous access, not an arterial access like TAVI. So, can you tell us about the access site and the size of the sheath and how you're going to close the access site?
I think because this is an interventionalist, actually, the structural, who would answer this question. We assess, the size of the valve, the imaging perspective, and that was the purpose of. So I wouldn't be able to say this because I'm not an interventionalist.
Okay.
Yeah, thank you.
Thank you. Yes, we have another question here from Dr. Ahmed Al-Said from Ain Shams.
I think the best way is trans-epical nowadays. Julia, you said that trans-epical. So a lot of cases to be done, which is easier to be done by the sheath introducer and then close by per-closure device after, because it's easy to go with the mitral valves through trans-epical approach rather than with transseptal, because the opening is very difficult and the rotation of the valve is not easy to make it. So I think it is just an early phases of transseptal approach to mitral valve replacement.
So thanks again for the very elegant presentation. I have two questions. The first one is, we know from the discrepancy of the data from the COAPT and the MITRA-FR that patients who have advanced LV dysfunction won't really benefit from the mitral clip. So those patients who have significantly dilated left ventricle and impaired function, ejection fraction below 20%, do you still operate or offer these patients mitral clip, or you defer these patients and consider the mitral clip a futile procedure? This is the first question. The second one is, once we have well-established transcatheter mitral valve replacement with well-established devices, how would imaging help us to decide which patient should still offered mitral clip and who should be scheduled for a mitral valve, percutaneous mitral valve replacement?
Thank you. So I will answer the first one. One second, the first one was about the
patients with advanced LV dysfunction. And
so we have a colleague in our hospital that he chooses to, he's an imager, and he usually is predisposed when a patient has an ejection fraction lower than 25-30%. However, our structural interventionists, they say to him that no, if we feel that this patient, the only way, for example, to be saved from heart failure, if they are on maximum medication and they are stuck in ICU with heart failure, and they have severe, for example, free flow mitral regurgitation, and the only way is to provide a clip or two clips in order to save them from the MR, we would do the mitral clip. So it's actually the clinical background, and if they would truly benefit from the mitral clip. So we have lowered our threshold for ejection fraction. At St. Thomas's, we are doing even ejection fraction 15% or so. Now, for the second part, you mean how echo can decide between transcatheter or mitral clip? Is that if I understand correctly?
I mean that in a few years we'll be having percutaneous mitral valve replacement devices. So how would imaging help us decide which patient should receive a mitral clip and which patient should have a valve replacement, percutaneous mitral valve replacement?
So that's, again, I think it has to do with the coaptation, the ejection fraction of the ventricle. If the patient is, heavy load to put a new valve in. So if the patient can tolerate this, the new valve, for example, the axis, the vascular axis, so it's multifactorial, actually, the decision of whether. We have 4 meetings every week. One of them is dedicated to mitral procedures, and we discuss everything about the patient. And then we make sure what is the appropriate access, what's the best procedure and what's the size of the valve that is best for the patient. So everything is like a multidisciplinary approach, and also with the surgeons if they want to do a hybrid procedure.
Dr. Julia, thank you for your lovely presentation. I'd like to ask you about mitral clip contraindications from the echo imaging point of view, especially if you find rheumatic etiology or history of infective endocarditis in your patient.
Yes, I think that's a good point, because in JACC case reports, for example, when they performed a mitral clip on a patient with previous endocarditis, they had to wait 6 weeks in order to sterilize the valve. So, of course, you cannot perform a mitral clip on a patient with endocarditis. Or, of course, when there is a flail leaflet, also, as we mentioned, the ejection fraction, if we go back to the Everest criteria, you know, they excluded a lot of patients in order to protect the results and to provide good results. So all the exclusion criteria of the Everest, and also we look at the anatomy of the valve. Sometimes also when a patient has a cleft, the structural intervention is strongly discouraged because they cannot catch the entire of the regurgitation. Now we use, for example, QLab in order to map the mitral valve and to know how many clips the patient will need. And if they need more than 2 or 3, then we maybe 3 actually is the cutoff for us. We consider this dangerous and we are not proceeding.
So I think this is our last question, Dr.
Yes.
Karim, yes, and then we have
Julia,
to
thank
move
you
the
for
next speaker.
the elegant presentation. I'd like to ask you from your point of view, and you mentioned you may use more than one clip. So what are the echocardiographic predictor that can predict that you will use more than one clip in your case?
So we use a 3D color Doppler, and we look at the coaptation zone and the coaptation line. And if this catches actually, if it's localized, then we feel that this is an isolated, localized mitral regurgitation, then we are confident that will be needed only one clip. But if it catches the whole of the coaptation zone, sometimes it may be a defect that it's very difficult to catch with one clip, and it may need more. So then, you know, we are doing actually, this is the key view, the 3D, the surgical view as we call it, and then to use color. That's why we have new softwares, and I appreciate that they're great new modalities such as the glass that gives us better viewing of the valve.
Okay, thank you so much, Julia. Actually, this was a very informative lecture.